Hi, very good morning, everyone. We are on 11th of April, the new financial year for a lot of countries. We would be, it's a first session in this April, and we are talking about a very important topic, nutrition in CKD. We have with us, and we are privileged and honored to have Dr. Rao. He's an highly accomplished clinician and academician holding DM, DNB, MD, DTDC qualification and is a gold medalist. He's also a fellow of International Society of Nephrology and currently serve as a clinical doctor. We are talking about the crucial role in improving outcomes and quality of life of patients with chronic kidney disease. Sir, over to you.
Good morning. Today I am going to talk about a very important topic which is a part of therapy for all patients of chronic kidney disease, that is nutrition. We are going to talk on the simplified way of using the information which are available in the literature to have a good quality life in patients of chronic kidney disease and at the same time having an impact on the CKD progression. So my thought process is simplifying the nutritional therapy in chronic kidney disease and taking help of the dietitian when it is appropriate, because most of the patients have more faith in the doctors saying something about the diet rather than the dietitian, though the importance of dietitian cannot be undermined. The nutrition as a therapy is so important that we have realized over the years, which gets ignored in the busy practice of the clinicians, and many times this is substituted by a fixed diet chart, which is not appropriate. We all are aware of the fact that non-monitored intake of calories, protein, sodium, phosphate has metabolic alteration in chronic kidney disease and its progression. The dietitian, if available in center or online, giving consultation, can bridge the gap for a busy clinician to implement the concepts. The link between the diet and kidney disease is shown in the slide. That kidney plays a very key role in nutritional homeostasis, that is ranging from regulation of sodium, potassium, phosphate, which comes from the diet, to the metabolism of amino acids and glucose, which gets usually disrupted in patient of chronic kidney disease, and hence it requires some degree of modification to keep the homeostasis stable. CKD patients are at risk of spectrum of nutritional disorder that encompasses undernutrition, protein energy wasting, sarcopenia, and electrolyte disturbance. We have to understand the term protein energy wasting is different from the malnutrition and sarcopenia, which we are going to discuss in subsequent slides. Dietary factors, therefore, have both the cause as well as consequence in the progression of kidney disease and its complication. So the first question that when we try to explain to the patient about the kidney disease, they ask, what can I eat and what should I avoid? And that becomes a very, very important question to be answered in a busy practice. So in this regard, when we talk about diet, we try to talk in the context of protein, sodium and fluid, potassium, phosphorus, calories, and supplementation in the form of iron, vitamin D, folic acid, or oral nutritional supplements. And these are the things which we incorporate in our discussion with such patients. So the common principles of diet, which we try to tell to our patients in the follow-up, is that patients who have an early stage of chronic kidney disease, that is stage 1 to 3, only requires, in most of the cases, a low sodium diet, which should be balanced in protein, calories, and other things like fat. But in stage 4 or stage 5 of kidney disease, which is called an advanced kidney disease, many times we require protein restriction to postpone the need for dialysis as long as is possible. Patients who are considered stage 5D, that is, who are on dialysis, it is said that the protein intake should be made adequate, though the habit of taking less protein continues even on dialysis in many patients with consequence of nutritional problem. It is very important that when we suggest a diet, it is not a fixed kind of concept which is used lifelong, but we need to monitor the patients by the ABCD formula that we'll talk about in the subsequent slide, and looking at the scoring of the nutritional parameters, which is called subjective local assessment, which is easy to do as a clinician. The challenges that we face as a clinician and when we talk about dietary restriction is that many people complain of anorexia or taste disturbance, which are usually treated with appropriate drug therapy as shown in the slide. Yeah, electrolyte disturbance, because patients of kidney disease could have all kinds of electrolyte disturbance will require dietary modification. Fluid restricted diet many a times will be required in people who are having less amount of urine with the edema. And special considerations are always a part of dietary therapy when patient is having diabetes, hypertension, or a mineral bone disease with calcium, phosphorus, PTS, vitamin D disturbance. In a pediatric patient, the diet may be different from the adult patient and the elderly, where we have to take care of the geriatric problems when prescribing a diet. So these are the challenging aspects, and hence there cannot be a fixed rule for every patient. As the GFR falls, the goalpost in diet therapy changes, as is shown in the slide that in patients who are having CKD risk factors and they are in the early stages of kidney disease, the stage 1 to 3, only general care is required, that optimizing, say, the glycemic control in diabetics, looking at the weight loss who are obese, looking at the other interventions which may be associated with better kidney protection, like reducing salt intake and processed food, increasing physical activity, which may be associated with better BP control. But as the patient's kidney disease worsens, that is GFR keeps on falling, one has to look at the therapies which may have implication in hyperlipidemia, proteinuria, hyperglycemia, and hyperinsulinemia. And in this context, reducing salt intake anyway is a part of therapy, increasing fruits and vegetables, because it has been found then that it may have a beneficial effect overall, and reducing the saturated fat. But when the GFR falls further, the dyslipidemia becomes severe, anemia is a problem, acidosis is there, chronic fluid overload is a problem with hypertension. And in this situation, fluid intake also becomes an important concept of in dietary restriction, lowering the protein of intake in the form of animal proteins, optimizing fluid of fruit and vegetable that they may have to be reduced in case hyperkalemia is there, and the fat has to be also reduced along with whole grain. And when the kidney failure, when patient requires, who are on dialysis, though the fluid intake has to be reduced, we can increase the protein and consider supplementation of the nutritional elements which may be there low, as iron deficiency or vitamin deficiency. So as the GFR changes, and the patient goes toward dialysis, the dietary goals keeps on changing. And that has to be understood before we prescribe a fixed diet chart. So this is considered to be a pyramid of diabetic management, which has been advocated for diabetic kidney disease, but it is also applicable in most of the patients of other forms of kidney disease, like non-diabetic kidney disease. That the carbohydrate intake should be not exceeding 60%, 50 to 60% is usual carbohydrate intake that is recommended, along with the protein intake of 0.6 to 8 in case the GFR is below 30. And the sodium intake should be less than 2 gram. Calorie intake should be 30 to 35 depending on the body weight. Fiber should be there, roughly 30 gram. And potassium should be guided more by the serum levels than the fixed way of not taking fruits. Calcium intake should be less than 1.5 gram, and phosphorus should be below 1 gram per day. So this is a general concept that when you talk about a patient of kidney disease, carbohydrates should be 60%, energy should be appropriate, sodium should be less, fat should be distributed between the PUFA, MUFA, and saturated fatty acid, the 10%, and protein intake may be reduced to 0.8 gram if patient is not malnourished. So when we look at the overall kind of prescription, normally we give patient not more than 0.8 gram per kg of protein with a GFR below 30. This comes to a calorie intake of roughly 10% of the total calorie that is we are planning 30 to 35. Of this, 50% should be of high biological value protein. That is, it should have all the essential amino acids. When we are giving a vegetarian protein, like soy protein, we may have to give a supplement to take care of the high biological value protein which may be deficient. So high biological value protein means proteins which are coming from animal source, and in case it is a vegetarian protein, essential amino acid may be required to be supplemented. The amount of carbohydrate that we give should not exceed 60%, because the higher the carbohydrate, higher is the risk of hyperlipidemia, particularly the VLDL cholesterol. And it is said that when you are giving this amount of carbohydrate, which is a major meal for Indians, less than 10% should be monosaccharide, that is simple sugars. And choices of high fiber food, carbohydrate, fruits, vegetables, and complex carbohydrate like whole grain and millet should be incorporated in the total kind of menu of such patients where dietary prescription has been changed. The fat, it is said that it should be always below 30%, because that fat is the major amount of calorie producing substance in the diet. And 1/3 of the fat should come from MUFA category, 1/3 from PUFA, and 1/3 from even the saturated fatty acid. It is said that roughly 7% of saturated fat should be contributing to the amount of fat that we give. And the energy to, or the calories that we talk about should not exceed 30 to 35 kilocalorie in most of the adult patients. So the normal amount of protein that a normal person takes is roughly 1 to 1.3 gram of protein per day, who are able to afford it. And that constitutes a calorie of about 15 to 20% in a normal diet. And when we are trying to talk about 0.8 gram per kg, it gives a calorie intake of 10%. So there are many gaps in the knowledge of in the dietary management of diabetic and non-diabetic kidney disease. What we know in the protein intake is that low protein diet may preserve the GFR in patients of kidney disease, but what is not clearly known is that what is the ideal amount of protein intake in a chronic kidney disease, and should this be applied in all patients with diabetic kidney disease. The dietary source of protein, when I talk about, it has been known that protein originating from vegetable sources are associated with slow progression to kidney disease. But what is not known clearly is that what is the exact effect of the different proteins which are a part of this vegetarian protein that is suggesting in such patients. When you talk about carbohydrate, what is known is that both high carbohydrate diet as well low carbohydrate diet are associated with poor outcome. But what is the ideal amount is still not fully agreed upon. Dietary source, what is of the carbohydrate, what is known is that whole grains, carbohydrate, fibers, fruits, and vegetables are recommended because it has got a kind of better outcome in the follow-up. But what is not known is that whether changing the carbohydrate food selectively results in the improvement in the DKD outcome. Prescribed diet that we're going to talk about, DASH diet, Mediterranean diet. Few things are known that DASH diet is associated with better BP control and decreasing the risk of diabetes and chronic kidney disease. Mediterranean diet is known to reduce the risk of cardiovascular events. But what is not known is that what is the effect of these diets ultimately on the kidney outcome, which requires to be further studied. When you look at the fat, what is clearly known is that higher ratio of PUFA to saturated fatty acid are associated with delayed progression. But it is not known whether the consumption of only PUFA will reduce the adverse cardiovascular events which are associated with both DKD and CKD. Sodium, we know that restricting sodium ultimately improves the cardiovascular risk in patients. But what is not known is what is the impact of sodium restriction on glucose metabolism and insulin metabolism. So some areas are clear, some areas are not clear, and this is what we practice in our day-to-day prescription. So what is shown in this slide is that Indians in general are eating more carbohydrates and less protein than recommended, both in the rural population as well as the urban population. So in an Indian scenario, the protein intake is already low in population, and which has been calculated to be 0.6 to 0.8 gram per kg. And hence, reducing the protein intake is going to produce malnutrition is the concept in our clinical practice. Avoiding common items like dal, lentils, which are commonly done by other physicians, can lead to a protein energy wasting. Therefore, the individualized diet plans rather than blanket ban on protein is needed in most of the patients. One has to understand what is the difference in the terminology of these nomenclature. Pure malnutrition is considered to be present when there is loss of body weight, muscle mass, and body fat due to insufficient energy and nutrient intake. But the protein energy wasting is different from malnutrition. That though it has a similar criteria, but it is associated with low-grade inflammation as an additional etiological condition, and hence protein energy wasting is malnutrition plus inflammation that we talk about in context of chronic kidney disease. The term sarcopenia and cachexia also has to be understood because people get confused with the terminology. Sarcopenia is understood as a concomitant loss of muscle mass and muscle strength that occurs usually with aging, while cachexia is a syndrome that is present with disease with chronic inflammation and increased breakdown of muscle proteins such as cancer, and is characterized by severe muscle loss with or without the loss of body fat. So when inflammation is there along with sarcopenia, it usually leads to cachexia. So sarcopenia is basically a syndrome characterized by progressive and generalized loss of muscle mass and strength, and it is not same as malnutrition that we talk about our protein energy wasting, though there could be an overlapping etiology which produces both protein energy wasting and sarcopenia. Progressive lean body mass loss is called sarcopenia. By the term lean body mass means fat-free mass. It affects roughly 30% of people over the age of 60 years and 50% by the age of 80 years. So it is a part of aging also, besides the malnutrition of protein energy wasting. So when we talk about sarcopenia assessment, three things that we look at is the muscle mass, muscle strength, and physical function, which are closely related. They may not have a causal relationship, and they are usually assessed by the mid-arm circumference health grip test or CT scan of the muscle mass or DEXA scan, which is different from what we assess in a patient of protein energy wasting. So this is the criteria which has been suggested to define protein energy wasting in context of kidney disease, where we talk about the ABCD concept. A for anthropometry, what is the height, weight, and the body mass index. B is basically a kind of body composition that we talk about in the form of fat percentage of muscle arm circumference change. And C is the chemistry, that is whether albumin or cholesterol, and D is the diet calculation, whether the patient is taking a low protein intake or less than 0.8 and low kind of calorie intake or less than 25 kilocalories. This is just to emphasize that we do not forget the things which are talked about in the criteria which is suggested for making a diagnosis of PEW, that is serum chemistry, albumin below 3.8, the body mass, the BMI less than 23, muscle mass, which is reduction in mid-arm circumference at 10% in 6 months' time, and dietary intake that we talked about, the protein reduction as well as the calorie reduction for more than 2 months. So this is the criteria to make a diagnosis of protein energy wasting, and if one has to have one criteria each in each category to make a diagnosis of PEW in the context of chronic kidney disease. So the 4 key categories for diagnosis of chronic kidney disease are the biochemical indicators. The weight loss indicators are more than 5% in 3 months or 10% in 6 months, with the fat mass more than 10%. Muscle mass loss of 5 to 10% in 3 to 6 months, and low protein intake, which are usually because of multiple factors in the context of kidney disease like anorexia, nutritional insufficiency, inflammation, acidosis, comorbidities, and oxidative stress, which has to be individually looked at to reduce the risk of PEW in chronic kidney disease. So when we talk about protein restriction in the context of chronic kidney disease, the benefit that is been theoretically pointed out is that it decreases the load on the remaining nephrons, that it reduces hyperfiltration injury, it improves oxidative stress as well as insulin resistance in who are diabetics. It is associated with low phosphorus, potassium, acid load or urea generation. It reduces proteinuria. It reduces the PTH blood level and thereby improves the CKD, MBD or mineral level bone disease. It behaves like a RAS inhibition in CKD progression. That is, it has an additive effect on the RAS blockers. It decreases the likelihood of death or delaying the initiation of dialysis by 40%, and it improves the lipid profile and uremic symptoms like pruritus. And hence, this concept was advocated in patients of chronic kidney disease in the later stages when the stage 4 or 5 is there in the dietary practice of such patients. So this is a very important slide to understand that when we talk about the hyperfiltration injury in CKD, in the nephrons, which are the functional unit of kidneys, are destroyed over time in CKD because it's a progressive disease, and whatever is the remaining nephron suffers from hypertrophy and hyperfiltration. And when the 50% nephrons are lost, the surviving nephron reaches the limit of the ability to compensate, and this is a time when you have clinical signs of CKD. And as a result, progressive decline of GFR occurs, which finally leads to a total loss of kidney function. So what is shown in the top slide, that there are seven nephrons which are working with the normal GFR, and as the nephron either gets damaged, like 4 nephrons, the 2 remaining nephrons become bigger in size, and it is having a kind of high flow. And as the time passes by, the surviving nephrons has more high flow, and which, because of increased flow, there is a kind of injury which leads to a kind of progressive sclerosis. So this is a kind of process which continues, and one of the reasons of high flow in such related injury is increased protein intake. So what is shown in this slide is that when we give a low protein diet, it behaves like it produces hemodynamic change, which leads to a kind of afferent arterial constriction. That is, it reduces a kind of glomerular hyperfiltration, and it behaves like a kind of RAS blocker by producing a kind of efferent arterial dilatation. And that is how this concept of low protein intake benefits the patient of chronic kidney disease. That is, it is reducing the interglomerular pressure and thereby the downstream events of CKD progression. So protein restriction has been the concept which has been advocated for a long time, and the concept is now shifting its focus from animal protein, the first class protein based diet, to a plant based protein or plant dominant protein, which may have a long term benefit in patient of chronic kidney disease. So we are talking about this protein restriction, but we are talking about protein restriction of animal protein based basically, and trying to shift the focus to plant based protein, a plado diet. So now that was about the protein. When you now look at the electrolyte, it is said that sodium is a very important kind of electrolyte or mineral which has to be appropriately looked at. Daily intake of sodium should be less than 2 grams for people who have a GFR below 60 ml, are associated with hypertension, volume overload, and proteinuria. And it has been seen that people who are taking protein sodium less than 3 grams or more than 5 grams have a kind of increased risk of cardiovascular event. The ideal intake of patients with hypertension is, our proteinuria should be a protein sugar in sodium intake of less than 2 grams and not to exceed at any point from more than 4 grams in a patient of chronic kidney disease. Now, when we talk about potassium intake, we need to understand that the normal intake is should be at least 1 milligram per kg. Potassium-rich foods are associated with increased slower progression of chronic kidney disease because it reduces systolic blood pressure, lower the risk of stroke, and higher bone density. So this is the reason why it is said that probably in the early stage of chronic kidney disease, we may give a potassium-rich diet, but in the later stages of kidney disease, we need to restrict it. The sweet spot which lies between for potassium is between not to go below 4 milliequivalent or not to go above 5.5 milliequivalent, because both the things are equally dangerous, and hence in general we talk about potassium restriction when the patient has advanced CKD based on the serum potassium level. So the general consensus for observational study is that high potassium intake should be allowed in patients in stage 1 or 2 of chronic kidney disease, while beyond stage 3, high potassium intake is associated with more rapid progression and all-cause mortality, and hence it has to be restricted. So no potassium restriction is generally required when the GFR is above 60. In CKD stage 3 and 4, we may allow some amount of potassium intake, 2 to 4 grams per day, but beyond that stage, it has to be just based on the serum potassium level, whether it requires to be restricted or not. Phosphorus is an important element that is to be also focused. Both, when we talk about phosphorus, we talk about organic phosphorus or inorganic phosphorus, which is coming from the animal source and the plant source. Higher phosphorus levels have been associated with worse cardiovascular outcome, and so also the lower phosphorus level, and this is associated with increased mineral and bone density abnormalities. Possible mechanism of phosphorus-related injury is increased vascular calcification, increased arterial stiffness, and induction of FGF23, which leads to left ventricular hypertrophy. It has been reported in meta-analysis that there is a 20% risk of death for every 1 milligram increase in phosphorus beyond 5.5 in patients of chronic kidney disease. It has been seen that the phosphorus is related to the protein intake also, and animal proteins are associated with higher phosphorus compared to the vegetarian source of protein like rice, peas, beans, and lentils, and hence people who are less animal and intake protein, they have better kind of phosphorus compared to those who are heavy non-vegetarian. And we have to look at that dietary aspect when we're talking about phosphorus restriction. So milk products and non-veg are the one which has higher phosphorus compared to the vegetarian source of phosphorus. So dietary source of phosphorus is shown in the slide that when we talk about phosphorus, it is the phosphorus which is getting absorbed. Rice has got a phosphorus which is 16 gram per 250 milligram of phosphorus. Only small percentage of phosphorus gets absorbed because it is associated with phytate. While chicken, fish, etc. has a very high amount of this protein and phosphorus, and it's 100% absorption. So the animal source of phosphorus is better absorbed compared to the dietary source. And when we are talking about the fast foods that we these days consume quite often, it has got phosphorus additives, and hence it is suggested that patients who are on advanced stage of kidney disease should avoid fast foods or junk foods which are available outside. The third aspect of the dietary prescription is, can we prevent the kidney disease worsening by drinking more water? Because this is the concept which has been prevailing in the society, that taking more water is good for kidney, but that has not been found in the studies. In the prospective cohort studies, water intake and the risk of kidney disease were studied, and it was ultimately concluded that in patients of chronic kidney disease, the relationship between plain water intake and progression of kidney disease appears to be U-shaped. That both low intake of water and high intake of water may be harmful, and we normally suggest the patient to take 1.5 to 2 liters of water if they are not having any edema or heart failure. So the dietary pattern, then we look at overall the individual nutrient restriction. While it sounds in theory to be very important, it doesn't translate into good practical dietary advice. People often consume mixed meals, and therefore it makes more sense to prescribe dietary pattern that rather than giving a blanket statement that don't take non-veg. Plant-based diets may serve as the ideal low-protein diet with added benefit of low bioavailability of phosphorus, because phosphorus control is important in late stage of kidney disease. So when we talk about the plant-based diet, these are the different types of diet which are there. The plant-based whole diet, the DASH diet, the Plado diet, which is plant-dominant low-protein diet, the vegan diet where totally animal-derived products are not taken, Mediterranean diet where the whole plant food is taken, along with lean meat, flexitarian diet where both food with periodic meat intake is there, and vegetarian diet with egg, dairy products like milk, lacto-vegetarian or fish can be allowed. So there are different kind of patterns of food intake which can be appropriately utilized in right patient. So the benefits of the plant-based diet or vegetarian diet is shown in the slide, that differing amino acid profile may have different effects on renal hemodynamics, including reduced expression of RAS system, because it has been seen that vegetarian diet or plant-based diet behave like a RAS blocker. That is, it reduces intraglomerular pressure. It has higher fiber content and low phosphorus load, increases bowel motility and nitrogen excretion, thereby reducing the uremic load. It lowers cholesterol and reduces incidence of metabolic syndrome. It also alters gut microbiome towards more saccharolytic type, which ferments dietary fiber to release short-chain fatty acids and promote gut barrier integrity. And it also confers anti-inflammatory properties. And these are the benefits which are suggested in the vegetarian diet. And hence, this is a part of all dietary prescription in the patient of chronic kidney disease. So when you talk about plant diet, fats are rich in MUFA and PUFA, which is good for cholesterol and body weight, lowers atherosclerosis. Omega-3 derived from the plant fats are less inflammatory, and plant oils are rich source of antioxidants like vitamin E. Plants are richer in anions than cations, that it generates less acid load. Plants are generally low in sodium, and phosphorus in the plant foods are present as phytates, which are not easily digested and produces lesser risk of hyperphosphatemia. So that's the reason the plant-based diets are now recommended. Many times people have a feeling that the plant-based diet may not have enough protein. What is shown in the slide is that the chana, rajma, milk, paneer, dal, matar, all of them contain a reasonable amount of protein and which can be given in our patients of chronic kidney disease to slow down the disease progress. So eating well is very important, and these what is shown in this slide is that all these kind of dietary sources can take care of protein even in vegetarian who are having a chronic kidney disease. So what is the preferred diet in patients who have kidney disease shown in the slide? That when we talk about fruits to include, the fruits can be included when the GFR is preserved, 2 to 4 servings. When the GFR is low, below 30 ml, instead of 2 to 4, we may give 1 food serving which has got lesser amount of potassium. 5 servings of non-starchy vegetables, 2 servings of starchy vegetables. One has to understand the difference between starchy vegetable and non-starchy vegetables. Because starchy vegetables may have a kind of consequence for the glucose control, but non-starchy vegetables will have benefits both of high fiber and low calories. Legumes must be taken because that will be the source of protein, which has less phosphate, and 2 to 3 servings are nuts and seeds, which are having a good amount of uh, vitamins and other kinds of trace elements which are good for health. Foods to exclude, particularly shown in the slide, that in the late stage of kidney disease, highly processed food, meat, dairy products in higher amount, and fruit juices has to be avoided, but not totally banned. Yeah, it has to be given in lower amount. So what do we follow is that in our patients, we try to talk about plant dominant low protein diet with sodium restriction, high fiber intake, and trying to assess the kind of compliance by 24 hours in collection of the protein. That is, we tell the patient to exercise daily, choose low fatty products, include oils which are having a kind of lesser amount of saturated fat, avoid high saturated fat, work towards low sodium intake, enjoy 1 to 2 fruits in late stage of kidney disease and more fruits in the early stage, include whole grains in the diet, and include lean protein supplement like lesser amount of baking of the meat products while consuming it. So this is a kind of nutritional intervention which have been suggested in the literature, that maintaining health and minimizing the risk from the comorbid condition is important, and that in this respect, dietary patterns have to be understood. Low salt intake in general has to be advised for most of the people. One has to look at the risk of hyperkalemia, hyperphosphatemia, and nutritional intake, and appropriately the drug or diet has to be uh, changed. So what do we do in our practice? We ask the patient who are having advanced kidney disease to become preferably vegetarian or occasional non-vegetarian. Take more vegetables. There is no restriction of dal. And in patient who is totally vegetarian, we give essential amino acid supplement to avoid amino acid deficiency. We tell them to avoid fast food in general. Occasionally they can take it, but not in general, it to be avoided. To stop adding salt to the food, chutney, papad, and pickles. One fruit like apple is suggested in late stages for mental satisfaction, because people are fond of taking fruits in the late stage of kidney disease. Fluids, we have to give 1 to 2 liters if there is no swelling. And dietitian online or sometime in center is also taken help of, along with charts for them to understand what are the items that they can take. Too much of diet interference, I have understood, leads to protein energy wasting and very poor quality of life. So the take home is that moderate protein restriction is the order of the day. It seems beneficial in slowing kidney disease progression without increased risk of protein energy wasting. Plant-based diet is preferred. Sodium should be restricted to less than 2 grams per day, and 3 to 4 grams is okay for people who are not having a kind of edema, hypertension, which is not controlled. Potassium-rich foods may have health benefits, and restriction is usually not instituted till stage 3. Phosphorus intake can have adverse effect on heart and bone and should be restricted to around 800 milligram to 1 gram in advanced stage of kidney disease. Diet of a diabetic nephropathy patient particularly challenging because of associated hypertension, hyperlipidemia, uremia, gout, and obesity. And in this situation, an individualized approach may enhance the impact of dietary management. The other concepts that has to be always looked at is that when you are trying to change the diet, there should be enough calories, 30 to 35 kilocalories is per se not obese, because that can otherwise lead to a kind of malnutrition because of weight loss. HMB, the hydroxymethyl butyrate based therapies have been found to have benefit on sarcopenia, and so also the keto acid supplementation and as well as essential amino supplementation is a person malnourished or vegetarian. Exercise, particularly resisting exercise and endurance exercise, 30 minutes per day for 5 days a week has been found to have a beneficial overall effect on the muscle as well as sarcopenia and overall health. Anabolic supplements, appetite stimulants are also a part of therapy because many patients are having a kind of poor taste and anorexia. Mental rehabilitation is also important part of dietary management because depression many times leads to a kind of poor intake. And in this context, you have to have a cognitive behavioral therapy. The final tips in the dietary prescription is that when you tell the patient eat fresh, avoid processed food. When you are getting food from outside, you should look at the label. Dining out is occasionally allowed in people who are on dialysis. Food diary has to be maintained to look at what is the person taking. The portion control is also important in those who are obese, that is particularly with relation to calories and other nutrition. And we need to take a dietitian advice periodically to see that the things are getting properly implemented. So that is all that I wish to talk about the management of nutrition in chronic kidney disease. If there are any questions, I am willing to take. Thank you.
Thank you, Dr. Jha, for a fantastic presentation. We really appreciate you coming onto the platform today to share your knowledge. I really feel that with chronic diseases, whatever we can do and how we can intervene with our own lifestyle modification is very important, and constant education and reminders is always valuable in slowing disease progression. Does anyone have any comments or questions?
Hello.
Hello. Dr. Jha, thank you very much for your time. Do you have anything else that you'd like to add, or do you see any questions that you'd like to answer?
I presented my views about the dietary management. We feel that probably many times too many players in the dietary therapy, including dietitian, fixed diet chart, which interferes with the patient's lifestyle. So we try to modulate that therapy, etc. We try to see that we can control those kind of ideas, because there's nothing called fixed rule in any patients of diabetic kidney disease or non-diabetic kidney disease. So as a kind of practicing physician, we try to take charge, because if we give the charge to other people, the things gets into many kind of problems which we are not able to comprehend, and that too much of interference in diet makes the people quality of life bad, as well as that doesn't serve the purpose. We may be giving a diet chart, but that is not getting followed. So the purpose is defeated in case we become too much mathematical in the process of dietary prescription.
Dr. Jha, it has been a very wonderful presentation, but I think listening to you only once is probably not enough. I think, can we get a recording of this particular very important, presentation, to listen to it again and again, so that ultimately your advice gets stuck to the what you call practicing physicians like me, even after having spent 5 decades in this profession.
Yes.
So I will request, can we have this recording? Because this has been a very wonderful presentation in all my life. Thank you.
Thank you.
Thank you. So that's my request.
Yes,
if we can have a live presentation, which I can listen to it again and again.
Yes, because there are many areas which we are learning over time, because we have not learned those things during our MBBS days. Yes.
I think, yeah, absolutely. Very nice, very nice. worth the time spent. Thank you.
Thank you.
Thank you very much. There will be a recording that will be made available on all the social platforms for you to review.
Thank you.
Thank you. Dr. Jha, if there's no more questions, thank you very much for
Dr.
your time.
Monica, Dr.
Yes.
Monica, sorry, I've raised my hand. Sorry. I just want to say again, also, this is a very, very nice presentation. But I've got one question, and maybe it's not a fair question, but how much kidney protection can we realistically be achieved through diet alone if we compare that with the modern therapies such as our SGLT2s inhibitors? Thanks.
The answer to this good question is that when we are trying to talk about diet and drugs, they are not competing with each other. Every person is on drug therapy, etc. So the pillars of therapy that we talk about, the RAS blocker, SGLT2 inhibitor, MRAs, are always a part of the patient's prescription beside diet. So they are complementary. We cannot say that the diet is less important or the drug is more important. Both of them have to be used for getting the results. And diet is always a part of life, because if person is not eating, not drinking, ultimately what is his life, etc. Because person has to eat well, he has to feel well, etc. And too much of interference in diet, what we feel many times see is deteriorating the quality of life. But if it is an unsupervised diet, it has been seen that they have the progression of kidney faster. That is, when they're taking a lot of salt, they're taking a lot of phosphorus, they're having more calories, more fat, saturated fat. They have either increased CKD progression or they have increased kind of cardiovascular mortality. So unsupervised is wrong. It's not the way to do it. We have to suggest it, and we have to suggest in such a manner that people are able to implement it, because ultimately suggesting things which cannot be implemented has got at least no purpose. So we have tried to simplify the things. We try to make the people eat, because not eating is more common than eating in Indian context. We find that more people are malnourished than are nourished when they do the dialysis, because of too much of interference, and most of the people are not taking enough protein. Anyway, we are deficient in protein intake, and when they do not take dal and other kind of items based on the WhatsApp news and other news, etc., they become more and more malnourished. And because of malnutrition, they are increased risk of hospitalization, infection, and mortality. So we want the patient to eat well to reach the stage of dialysis with proper kind of supervision that is always recommended.
Thank you. Just one more follow-up. It's really a very, very good presentation. So we didn't touch on vitamin D. I know you can't eat vitamin D, but the role of vitamin in the phosphate is actually very important, especially in your kidney patients. So it is important to look at your electrolytes. Thanks.
Yes. So
Or your levels.
yes, we in general are supplementing vitamin D in all our patients because of lack of exposure to sunlight, because of AC condition and change in environment. Most of the people are deficient in vitamin D wherever we have checked it. So this is a routine practice to give a supplemental dose of vitamin D in all patients with chronic kidney disease. We have hardly seen any patient who are not been supplemented to be in normal range, etc. So 95% of people are having a vitamin D deficiency, and we give it as a routine in all our patients. Vitamin D is not only a vitamin for bones, but it has got an immunomodulative function, and hence it should always be checked and supplemented.
Thank you again. Very, very kind of you to share all your knowledge, and we appreciate your time. And we will definitely have you come back again. It was a fantastic presentation.
Thank you.
Thank you.
Thank you. Goodbye.
Bye. Bye.